of you. Today's academic meeting is on uveitis, and it's a very practical oriented meeting on case reports and management as per the case reports by one of our most favorite and famous famous specialist, Dr. Amala George from Sankara Nethrayala. Welcome, ma'am, to Thrissur, and thank you for agreeing to come so promptly.
No. I have to thank you very much. I don't deserve these words. Always happy to go back to the home or to my.
Yeah. So I'll invite the chairperson for this session, Dr. Papa. Chair, please take over, and Dr. Sujata will kindly introduce the speaker.
Good evening, ladies and gentlemen. It's indeed my pleasure to introduce today's speaker. Dr. Amala Elizabeth George is currently Senior Consultant in the Uveitis Department of Sankara Nethrayala. She completed her medical graduation from St. John's Medical College, Bangalore, and National Board of Examinations, Diploma of National Board of Examinations from Sankara Nethrayala. She was awarded Fellowship of the Royal College of Surgeons in 1999. She specialized in uveitis and intraocular inflammations at Sankara Nethrayala from period 1998 to 99, and has been in the UVA department of Sankara Nethrayala since 1999. She has published more than 25 papers in the national and international journals and co-authored about 2 books. She has presented over 50 papers and posters in international and national ophthalmic conferences. And also she has been invited as a speaker at both international and national conferences. She's involved with multiple uveitis trials and has been member of the Uveitic Society of India since its inception, and is currently a member of its executive committee. Today, she is going to talk to us about uveitis case scenarios and management. Let us all hear what she has today. Let us listen to her words of wisdom. Over to you, madam.
Thank you very much for your kind words. And once again, thank you for letting me be part of this TACO meeting. I'll just share my screen. Is it visible for everybody? Can I start? Is it visible?
Yes, madam.
Yes, madam.
Yes, madam.
All right. Okay. So I thought today, for the cases, I just want to just a minute. I just want to talk about our approach to the diagnosis and management of uveitis, especially chronic uveitis, and how we order and why we choose certain investigations. And frankly, for diagnosis, the most important thing is to isolate the anatomical location of the primary uveitis and the patient's demographics. What is the age range and the history of the episode? Because without this, we really cannot narrow down the amount of lab work that we need to do, the imaging and the physician involvement that we need. See, for example, with anterior uveitis, that's the most common form. I need to know the age of the patient, vision, if it's reasonably good, that's nice. Again, IOP issues. So if I see somebody like this, my first priority is to use intense topical steroids and try and dilate, use atropine if required, see the fundus. So if the fundus is normal, then we're dealing largely with idiopathic uveitis or B27. We will be asking a lot of history to see whether the patient had a recent episode of fever, a medical procedure, dental, anything like that, to see if there's an infectious etiology. So all of this should have happened in the history also. And of course, some basis related history in case there is a hypopyon. We don't normally have a hypopyon in every patient. But if you're going to see somebody who has been treated for more than 6 months as chronic anterior uveitis with topical steroids and multiple JAG PIs with an occlusio pupillae, no view of the fundus, vision is hand movements close to face. Now, at this point in time, the first thing I need to do is look at the posterior segment. So here, yeah, posterior segment was showing us total retinal detachment with shifting fluid and increased choroidal thickening. So for this patient, our working diagnosis has to be some form of VKH. Now, after 6 months, the situation is not very good. But again, with intravenous methylprednisolone, some amount of azathioprine, surgical PIs, the vision has improved even without the cataract surgery being done. The lens was actually relatively clear in this patient. And we just needed to, at the time of the surgical PI, dilate the pupil a little bit and get rid of that membrane. And so that we could avoid doing a cataract surgery at a time where it is very unfavorable for us to do a surgery. So with this, the patient was able to manage, maintain vision, do some amount of work, and then we operated him later once the situation was a little more stable. Now, again, if you're seeing a child with a very quiet eye, posterior synechia, a little bit of band-shaped keratopathy, vision may even be reasonably good. The posterior pole through this non-dilating pupil may look normal. But these are the signs that are going to tell us that this has to be either part of chronic intermediate uveitis or juvenile rheumatoid arthritis. So investigations need to be targeted. A lot of physician involvement, especially the rheumatology involvement, needs to be there, and some form of assessment about how much inflammation is going. So if the patient's a little older, we can always do a UBM, but to see if there are pars plana membranes or not. Otherwise, no, we have with the child, I'm not really very keen on putting the children under GA. So for a patient like this, even if I can't see that there's much evidence of active uveitis, we might have to start, depending on the vision, some amount of methotrexate and very low doses of steroids and see how the patient progresses over a period of time. The keratic precipitates, of course, are a big guide to what kind of investigations we select, the granulomatous or non-granulomatous types. It's good to look for corneal involvement. Sometimes it's in the periphery and it's very small, but anterior uveitis, especially with raised IOP, can be viral. And so some of them may have very few small corneal lesions. The other thing is hyphema, which is sometimes can be very isolated, very limited. So we may miss it when we see a patient with inflammation and a spike in IOP. Fuchs heterochromic iritis is still quite common, but the important thing here is to look for iris atrophy. See, there's a difference in the structure of the iris in both the eyes. So that's what gives it the hypochromic look. But in the absence of this iris atrophy, I'm reluctant to call anything Fuchs uveitis. If it is only just a few diffuse KPs and a unilateral cataract, I will still investigate as we would any case of granulomatous anterior uveitis. But if the patient does have this distinct moth-eaten appearance of the iris, then yes, you're probably safe to call it Fuchs heterochromic iritis, which, as we know, is probably related to rubella. And we can go ahead and manage it with minimal steroids involved. So for anterior uveitis, just first of all, we need to confirm that it's anterior and get some view of the fundus as soon as possible, especially the periphery. And watch out for cases involving children, if there are band-shaped keratopathy, narrow angles, especially without iris bombay. Just a narrow angle means there must be some rotation of the iridociliary body. This, and of course, the intraocular pressure needs to be always kept in mind. Now, most of the chronic forms of uveitis tend to be intermediate and posterior. The issues with chronic uveitis is different. Now, we have so many drug and disease-related side effects, both ocular and systemic. The compliance with follow-up can be very variable, and so just encouraging patients to continue with care and follow-up is also important. The sheer expense of medication, the amount of imaging and investigations we need to do periodically, the surgeries that are required for the complications that come up, all of this makes chronic uveitis a very difficult proposition. especially some of them end up with decades of treatment. For example, this is a patient who is now 45 years old. He presented after 5 years of disease duration. He has bilateral disease and secondary open angle glaucoma. He had already been operated in the left eye. A very well done phaco IOL had been done, but despite that, he was progressing. So over the next 12 years, the systemic workup was negative for everything. He was on azathioprine and steroids, and after a year of getting things under control, a planned phaco trab was done in the right eye, which is retaining good vision and is reasonably healthy with minimal activity till now. In the left eye, however, we've had trab, retrab, late IOL decentration, SF IOL, and is slowly developing corneal decompensation. He still has useful vision, but we are not sure how long we can maintain this vision for. Now, and that patient was 45 years old. Now, here we have a girl with the onset of uveitis at the age of 8 or 9. She was manto positive. Anti-TUP medication was given, followed by anti-toxoplasma medication, and of course, oral and topical steroids were tried. At age 11, she underwent phaco, foldable, then followed by vitrectomy 6 months later, and capsulotomy. So when she reached us at age 13, her vision was 1/60 in the right eye, 6/60 in the left eye. IOP was normal. We could see anything because of deposits and membranes over the IOL. Ultrasound also was not very informative. The retina was attached, vitreous appeared relatively clear. No specific choroidal thickening was there, but it's important to get the baseline axial length measured in these individuals. 19.3 in the right eye and 20.9. So that's sometimes one of the only ways to know whether this eye is slowly going into phthisis. Again, investigations were negative for everything. So now what do we do? See, the factors that are in my mind are, one is, now we have girl, young age, bilateral disease, partially controlled chronic inflammation, multiple surgeries done, and no specific systemic etiology. So after 6 months of immunosuppressives and steroids, we planned the YAG capsulotomy, repeat YAG. There was a small spike in the IOP following the YAG, which was controlled with timolol and was back to normal in 3 months, and we could take her off the anti-glaucoma medication. Vision improved to 645, and in the left eye, it was improved to 6/7.5. But we have very limited view. It's a non-dilating pupil, and this is the best we've ever seen of her fundus. We tried to get the OCT, at least in the right eye. We could see that there was diffuse thickening of the retina. There was foveal thinning and diffuse thickening of the retina. Left eye, the image quality was too poor. By age 15, age 16, she was maintained on azathioprine and the maintenance dose of oral steroids with topicals up and down. We needed a re-YAG at age 15. This time there was no spike in the IOP in the left eye. And then we had the pandemic coming in, lost to follow up for a while. And by age 17, 18, her vision had dropped back to 1/60 in the right eye, and IOP was now 4. Left eye, it was reasonably all right, but there was a lot of flare. We gave her a full course of oral steroids and posterior subtenance tricot at this point in time. Continued with the azathioprine. And in 3 months later, her vision improved to 6/60 in the right eye. IOP, however, remains low. In the left eye, again, the IOP did not go up. This is not a very great sign. So, I mean, I don't want glaucoma, but again, I'm worried that this sort of a patient is going to end up with phthisis in a few decades. At this time, we had a better view of the posterior, the OCT of the posterior pole. Still a lot of retinal edema in the right eye, but the right eye visual prognosis is very poor because of the foveal thinning. The left eye is still reasonably healthy, a little bit of subretinal fluid, subfoveal fluid. So at this point in time, at 17, 18, we've already repeated 1 course of oral steroids. So we've decided this time we're going to have to, in the long run, try and increase the immunosuppression now, but keep the prednisolone at the maintenance dose. We also repeated the triamcinolone. Now with going to posterior and panuveitis, very often things are a little easier in this because there are many very typical ways of presentation and typical pictures in posterior and panuveitis, unlike with intermediate uveitis. For example, when you're seeing multiple discrete areas of choroiditis, very likely we're dealing with APMPP, or again the necrosis seen here in toxoplasma retinochoroiditis, and the more diffuse type of choroiditis seen in serpiginous choroiditis. So many of them are very classic pictures, and we can investigate accordingly. Sometimes either by the history or examination, you know that one eye has suffered either trauma or surgery. And so when the fellow eye appears with some amount of fluid, or there's bilateral disc edema and fluid at the posterior pole, I think we're probably dealing with sympathetic ophthalmia. The absence of surgery or trauma, of course, bilateral disc edema and exudative retinal attachment is VKH. And we have a lot of investigations that we can do in a case of posterior and panuveitis to confirm our diagnosis. So this is the pooling of the subretinal dye in the previous patient, the patient with VKH. And of course, with follow-up, about a month later, things are looking better, still a lot of subretinal fluid, but it is less than before. Doing serial fundus pictures is useful because the picture changes over a period of time, even the absence of very dramatic activity. So 6 months later, this is what the fundus looked like. And this is now 5 years later. The depigmentation progressed, the amount of chorioretinal atrophy. And it's very difficult to follow up sometimes patients like this. Patients' vision is good, 6/9/N6. But 6/9/N6 is sometimes not very easy for us to decide whether or not there is any ongoing activity. This is where the OCT has really become useful for us. So we know that if we're dealing with some amount of cystoid spaces, or is there thinning, how much of loss of the ellipsoid layer and all that is occurring in the long run, this is better delineated by the OCT. And this is my last case for today's session. And see, this patient is 38 years old, and he had gradual decrease in vision in both the eyes over the last 1 month. He had been diagnosed with intermediate uveitis, not much anterior segment involvement from the beginning. There was vitritis, according to the previous reports. And he was started on 80 milligrams of steroids and was being tapered. Tuberculin test was positive, IGRA negative, HIV 1 and 2 negative, and the chest X-ray was normal. Vision steadily worsened. 6/60 in the right eye and 3/60 in the left eye when we saw him. And this was the picture of the posterior pole. As you can see, this whitish looking area is definitely looking like retinitis. The vision is still very poor. So the color vision was depressed substantially. There was no specific RAPD because both eyes were involved. And that's the fundus. You can see the extent of the retinitis, and it was only it's important to dilate and see some of our patients on visits, especially once we started patients on steroids, because an undilated posterior pole viewing is likely to miss changes that are happening in the periphery. And until this appeared within the posterior pole image, the repeat dilatation had not happened. So that was probably why the retinitis was missed. This was the left eye. So now we're dealing with the retinitis. So the possibility of infective etiology is there. And it's already treated with high doses of systemic steroids. So this patient, our main worry was he was immunosuppressed. So are we dealing with iatrogenic or underlying immune deficiency? And what sort of organism is causing the retinitis is what we're worried about. So for this patient, it was worthwhile to repeat the HIV 1 and 2 because of the extent of involvement, and it is very important to know this. Also tests for syphilis, CMV, toxoplasma, hepatitis B and C, and we wanted to know what the CD4 counts were. So, as you can see, the investigations revealed tests for syphilis were positive, the positive VDR, the RPR test. Now, other tests like, toxoplasma IgG was positive, CMV IgG, HSV and all were, but these are not really relevant. So again, it's really important when we order a lot of tests to decide which test is actually the relevant test. And the other important thing we found was, HIV was definitely negative and that the CD4 counts were normal. So we don't have too much of systemic immunosuppression to deal with. So we consulted the infectious disease specialist who advised benzyl penicillin and a course of benzyl penicillin followed by weekly benzathine penicillin, CSF analysis, and a repeat VDRL after 6 months. Now, when we saw the patient was on prednisolone tablets at a dose of 40 milligrams per day. So are we going to stop it or not? No. With this degree, with any kind of syphilitic retinitis, and looking at the extent involved, this is quite severe. There's a lot of paradoxical reactivation which occurs once we start the antibiotics. So we kept the prednisolone at 40 mg and tapered it very slowly by 5 milligrams a week. Reviewed the patient when the prednisolone was 20 milligrams. And the as you can see, the vision had improved, retinitis had all cleared up. The color vision had improved. He was back to reading all 21 plates, but responses were slow. The CSF and the MRI were both normal. Now at this point, we need to do the OCT. There are some cystoid spaces, minimal thickening in the right eye, not all that much in the left eye. Now 6 weeks later, so we tapered the steroids gradually and reviewed the patient 6 weeks later when the steroids were 5 milligrams a day. And at this time, he was on weekly benzathine penicillin. And as you can see now, in the right eye, the cystoid macular edema has increased. Still no areas of retinitis, so that is good. And in the left eye, which was the worst eye to begin with, you can see the loss of the retinal vascular architecture here in the areas which were involved. But the fovea was reasonably healthy, no edema at the fovea. So at this point, we have increased the prednisolone. We've asked them to continue with the benzathine penicillin until we can manage the inflammation in the right eye. So that was just to talk about real-time management of some of the cases. Now, when we look at investigations, most of the time we have to decide how relevant they are and what the expenses involved. The accuracy, or what we can say, the positive predictive value of many of the investigations. So investigations for syphilis, HIV, hepatitis, the B27, B51, tissue biopsies, tumor markers, imaging are always worth it and relatively reliable. They're not 100% reliable, but still better than most. A lot of our immune-related investigations, the ANAs, the ANCA, the sarcoid-related things, not so reliable. Again, there are many tests for infections which are not always very reliable. So it's important to order them only when we have already a high index of suspicion for some of these cases. The TB issues. Now, in our country, with TB being endemic, we have to really know the fallacies of the test, how reliable a manto is in a endemic country. So we can't really diagnose it based on a single test. It is a combination. Now, in a particular clinical scenario, the history of the patient, multiple tests, and most importantly, opinion from the physician, whether it is worthwhile giving a course of anti-TB medication when it is a non-specific kind of uveitis. So obviously with a choroidal tubercle, we are going to probably go and treat with anti-TB medication. For everything else, it is a little bit, it's a difficult decision to treat with anti-TB medication. Wherever possible, we need to see if we can get a sample for a biopsy, preferably from a systemic lymph node or lung biopsy or something where we can actually see AFB, and if possible run a gene expert to see if any drug resistance is there. The aqueous and vitreous PCRs are being done but are not very reliable. And we have to remember that when we add rifampicin, it reduces the efficacy of the steroids that we are using to control the inflammation. So we have to compensate for that. So we do need higher doses of steroids and for longer time if we are adding the systemic steroids along with anti-TB medication. Otherwise, we tend to have a lot of reactivations. Again, this is not there in mild cases, for severe cases. And of course, we have to monitor the liver function test. And just before ending, the biologics. So far, we've not had very great success with biologics. The expenses involved, and with TNF inhibitors, the TB issue, and the fact that many of them lose efficacy after a while, and or if depending on the monetary situation, we may not be able to continue with biologics in many patients. So the ideal situation is to use it for a very short duration in very severe uveitis. If there is failure of adequate standard immunosuppressive therapy, of course, if it's part of a chronic long-term systemic disease like GRA, where the rheumatologist is also involved, then also biologics may apply. So just to avoid cases from becoming chronic, I always feel that the most important factor is the control of the primary episode of inflammation. And if the patient has recurrences, also prompt treatment and control of the recurrences is very, very important. That's the only thing we can do to prevent the cases from becoming chronic. And fortunately, now the situation is so much better than in the past, and many patients, because of widespread awareness and control of and availability of the drugs, the cases that we see now are not really as bad as what we were seeing 20 years back. So for control of inflammation, we need to have an adequate dose of the steroid if you're using it. And in case of recurrences in non-infective cases, we should not hesitate to start standard immunosuppressives. And none of this is possible without gaining the confidence of the patient by discussing the disease. And we should not frighten the patient, but also give them some amount of hope so that they will continue with the treatment and the follow-up. We need to order appropriate investigations. We have to show concerns for the expense involved. And sometimes the complications and recurrences can be asymptomatic. And that's the reason why it's so important to stress the importance of follow-up in patients who have had uveitis. And so with all of this now, success rates for and achieving permanent remission in uveitis is definitely possible. So thank you very much.
Thank you, madam. That was a very interesting, very practical actually. I was very interested in that 8-year child you mentioned, that
Yes.
presented at 11 years. You were not able to find a diagnosis yet, no?
No. See, by the time, and if you see the patient after several years, see, very often we are seeing patients after 5 years or 10 years of disease. So we have often lost the original few years. The best chance for identifying an infection, an infective etiology or anything is right in the beginning. And for these patients, to do the local ophthalmologist credit, they had done the investigations. The Manto was positive. They'd given a course of anti-TB medication. I think ELISA titers for toxoplasma, they've given a course of anti-toxop. So from the infection side, they have done whatever they could do. So what can you do? See, very often a
Isn't that the problem? Isn't that the problem? Are we giving ATT based on Manto? Is that correct? I mean,
I'm not in favor of giving ATT based on Manto, because in an endemic country, a Manto is meaningless. You can give ATT for every patient with diabetic retinopathy if you're going to ask for a Manto in diabetic retinopathy, for example. So that's why I prefer to coordinate with a physician who is local and can follow up the patient regularly. See, TB is not going to sit silent. So,
Right.
And a competent TB physician knows if they're dealing with tuberculosis or not. And if you can actually get a lymph node or something somewhere where we can, actually go on something real, then it is still better. Otherwise, we end up seeing a lot of patients for whom, yes, the ATT has already been given. We don't know what use it is.
Yeah, exactly. A
And,
cocktail kind of
yeah,
a thing,
so
picture.
and it more than that, it tends to waste a lot of time. And if we waste a lot of time, these things become chronic. So
And plus steroids
yeah.
also we don't give because we think
Yeah.
TB. Actually, guidelines have come recently, no? The collaborative TB trial.
Yes.
So how,
We did not agree with a lot of things in that. So
you're part of the group. Huh?
Yeah. So, but yeah, there are guidelines, and but there was not really very much consensus. The only consensus that everybody was happy about was proper large choroidal tubercle with subretinal abscess, and almost everybody was comfortable only when you had positive radiologic investigations. Just relying on both the TB, the Manto and the quantiferon, nobody was very comfortable with that, even though the opinion varies from person to person. And I think we end up being biased because we tend to see a lot of patients for whom ATT has already been given, and then what are we going to do? So that's why. So I'm sure some of the cases, yeah, it's required, but difficult to diagnose it. Yeah.
No, at this age, like you gave at 11 years, you started steroids, and she is now 18 years.
Yeah.
I mean, doesn't long-term steroids are affecting the child's growth, no?
Yeah, but we started her on azathioprine. So the first thing we did is we always give one full course of oral steroids because it's important to get everything under control. After that, the patient's only on maintenance steroid. By maintenance steroid, it means it has to be below 10 mg. So if you're below 10 mg, the growth of the child is not affected. Now, she's taller than me. But I don't want them to have to repeatedly use systemic steroid. And what we have changed from the past, at least, is I think I was probably underdoing the immunosuppressive. We were removing the immunosuppressive very fast. Now we're a lot more comfortable with keeping the patient on the immunosuppressive, because in the long run, that is safer for the patient than repeating steroids again and again. And
so how long could you give safely?
We are not out of the woods for her in any case, because these patients will eventually go into phthisis. That's what we're worried about. So after 10 or 20 years, what have we gained finally? We're losing the eye. At least one eye we are going to lose. The eye which is showing hypotony, it's going to be very difficult to maintain that. She's only 18 years old. I don't know how we are going to maintain vision for the next 40, 50 years. So at least the better eye is what we're trying to see, whether we can maintain IOP. So monitoring the IOP, especially if it's going lower, is what is worrying. So that is what we're looking at. And if we cannot see the fundus, we have to monitor with serial ultrasound, B scans, and the axial length also, to see if gradually the axial length is shortening. So, but there are people whom after about 10 or 20 years, then we are suddenly over the wood. The IOP stabilizes, we're able to taper the steroids gradually. And first I tend to take off the steroid and then the azathioprine. So as we're taking the steroids down from 10 mg down to 7.5, 2.5 alternate days, and if you're not getting reactivations for a year or two, then we start taking down the azathioprine. See how many times we need to increase the topical steroids, or how many times we need to give periocular injections. And if we don't need to do many of those things, then we can even comfortably take them off the azathioprine and try and see if we can maintain the IOP. They will need to be on a follow-up, but that after a few years, we should be able to take them off medication. And that's when we say, we've achieved remission. It's so almost like in a treatment of a cancer patient or something. We have to treat till that last bit of inflammation is over. And then after that, you're pretty safe. So.
Amala, what was the original cause? Cataract, 8-year-old child. Is it a congenital cataract or complicated cataract? What was that? I missed that.
Yeah, it was steroid related. See, again, in a child, we again do not want to put on any topical steroid at all. So even if the patient's got any kind of anterior segment involvement, when we see the patient, it is non-steroidal drops and a cycloplegic agent. I don't want to put topical steroid at all unless, like, if there's a lot of inflammation for the very first time, yes. After that, cycloplegic agent and a non-steroidal drop, and the bulk of the work has to be done with the immunosuppressive drug, not with the topical, because that is the most steroid-induced, cataract-inducing thing. And that's not the age for us to do cataract surgery, because, you know, they don't do well. The IOL calculation is all wrong, and that 6/60 in one eye, which we are saying, that is with -9. So by the time she's 18, already her IOL power is now -9. So that is.
Actually, we had a case somewhat not this young, but some around, I think 27 years. She came with only decreased vision. And what was seen was the stellate kind of KP scattered all over the cornea. So the PGs diagnosed it as Fuchs.
Yeah.
But the patient actually presented with complicated cataract. For the past 4 years, she's having decreased vision or something, but not noticed any kind of uveitis symptoms. So is that the age for Fuchs? And I mean, except for the KPs and a few 1 or 2 cells, there's nothing else. The problem was systemically she was having anemia also, which was not diagnosed. So I was thinking maybe some vasculitis. The view, fundus view was not there.
Yeah.
That and unilateral case, the other eye was normal completely.
No, that's what, see, I would prefer to always investigate if I don't see the iris atrophy.
Yeah.
See, without iris atrophy, I don't want to label anything as Fuchs. I would rather investigate for granulomatous, at least granulomatous forms of uveitis. And of course, like you said, the anemia and all that. The routine workup will be done, and we can take it. See, with Fuchs, the iris atrophy is almost present in everybody. So otherwise, it looks very similar to any granulomatous uveitis. The rest of the features can occur in many other things. And Fuchs can occur in any age, actually, since it's almost certainly rubella related. It can occur at any age, and it is usually silent. There's no major drama, and no major events even after the cataract surgery.
It's related to rubella. That's
yeah. So there's now a lot of evidence that it is probably related to rubella. But most importantly, in the West, after the rubella vaccination program they don't have homegrown cases of Fuchs. All the Fuchs are coming in immigrants. So it is only from countries where MMR is not very well thing. And so we do try and ask patients if they had received rubella MMR vaccine. But in our country, it is not easy. Most people have no idea whether what vaccines they've received or haven't received. And we did try to get the AC tab for rubella, but very late presentations, you may not even get anything. But there are many reports from around the world with AC tabs confirming that it's probably rubella related. And the interesting thing is they're all in immigrants from countries that have not received, which don't have a universal vaccination program. So in the US, I think after the 1990s, they don't have a local case of Fuchs. So the incidence of Fuchs dropped after the rubella vaccination program started by almost 90%.
That's great. Any other questions? We have a case presentation actually on uveitis. Please sit for.
Oh yes, sure.
Dr. Jinsey and Dr. Papa, please take over.
Dr. Jinsey, you can start presenting.
Yes, sir. Good evening, everyone. Today I'll be presenting a case of bilateral granulomatous panuveitis in a young female patient. Now, a 32-year-old lady presented to our OPD with no known comorbidities. She had chief complaints of recurring episodes of headache, eye pain, defective vision in both her eyes, and her symptoms actually began around 10 months prior to presentation here. The present episode began since 3 weeks prior to presentation. In the present episode, she had sudden onset pain, redness, and defective vision involving her left eye more than her right, associated with a left-sided broache and nausea. Now, she was already on treatment with systemic and topical corticosteroids after consultation outside, but her treatment was actually irregular. She was taking steroids off and on. Symptoms subsided on treatment, but recurred when it was stopped. She has been off treatment. She had been off treatment since March 2020, post-COVID lockdown, and she was lost to follow-up. She also gives a history of tinnitus, vertigo, and earache around 3 to 4 years back, but there was no evidence available for that, and it actually spontaneously resolved. There was no history of any ocular trauma or ocular surgeries, no other significant past medical or surgical history, and no other significant family history. Now, on examination, there were obvious signs of iridocyclitis in both her eyes, with diffuse and circumcorneal conjunctival congestion, fresh keratic precipitates, both fine and medium sized over the endothelium in both eyes, and anterior chamber reaction with a 4+ cells and a 3+ flare in both eyes. The iris also showed nodules, both Keppes and Busakas in both eyes. And the pupil was around 3 millimeter in both eyes with irregular, irregular shape with broad posterior synecdoche. There were also pigments over anterior lens capsule in both eyes. Now, in the left eye, in addition to features of anterior uveitis, she also had stromal edema and epithelial edema. And there was an irregular anterior chamber depth with shallow peripheral anterior chamber and an obvious mid-peripheral bowing of the iris suggestive of iris Bombay. These were the clinical pictures at the time of presentation. So this was the picture of the right eye showing multiple iris nodules. And this is a photo taken at the slit lamp showing the iris Bombay. Now, fundus examination at presentation was not possible because the pupil was not dilating and media was very hazy. So not much details of the posterior segment could be made out. Now, vision in the right eye was a 2-meter counting fingers, and in the left eye was hand movements with projection of rays accurate in all 4 quadrants. Intraocular pressure at the time of presentation was very high in the left eye with around 46 millimeters of mercury by applanation. Now, gonioscopy in the right eye showed grade 2 angles by Schaffer's grading in all 4 quadrants with peripheral anterior synecdoche at 12 o'clock, 3 o'clock, 4 o'clock, 7 o'clock, and 9 o'clock positions. In the left eye, none of the angle structures could be visualized. Now, we investigated her up for for anterior uveitis, and her blood panel workup came back normal except for a raised total leukocyte count, which was around 11,900 with a dominant neutrophil count and a raised ESR of 40 millimeters in the first half. The immune panel workup also came back negative. HLA B27, B51C, and P-ANCA were all done. All these were negative. And a workup for tuberculosis, including chest X-ray, Monto test, and syphilis, VDRL test was also negative. Now, an ultrasound B scan was done, which showed a fine internal heterogeneous vitreous echoes with swirling motility with movement of eyes. There was no evidence of any retinal detachment or any choroidal thickening. Now, these were investigations she had with her at presentation at the time obtained at the time of the first episode of inflammation. The fundus photographs showed multiple posterior retinal hypopigmented lesions with macular edema and pigment epithelial detachments in both eyes. The fundus autofluorescence pictures here showing multiple areas of autofluorescence, and the OCT pictures at that time showed multiple pigment epithelial detachments in both eyes. Now, a fluorescent angiography was also taken. This was at the time of initial episode, and it showed typical starry sky picture expected in a Vokoenaga-Harara's disease. Now, with all this, diagnosis of bilateral granulomatous anterior uveitis with secondary angle closure glaucoma in the left eye due to pupillary block mechanism is based, with probable etiology being immune mediated, with diagnosis of Vokoenaga-Harara's disease in the chronic phase made. She was started on treatment with systemic steroids. IV dexamethasone was started and topical steroids, prednisolone acetate eye drop simultaneously to control the inflammation. Because her problems in the left eye pertained to the secondary angle closure from pupillary block, an NDAC peripheral iridotomy was done after initial lowering of intraocular pressure with systemic acetazolamide and topical anti-glaucoma medications. Now, this was the response. There was drastic response, and even the inflammation actually subsided after PI in the left eye. Gonioscopy showed opening up of the angles in the left eye. It was in the left eye, and systemic immunosuppression with mycophenolate mofetil was started later in consultation with the rheumatologist. Other consultations from the ENT and neurology departments were taken, but the evaluation there did not reveal any abnormality. Now, after treatment, she has been on regular follow-up since the past 5 months, and the inflammation has settled and controlled well in both eyes. The topical steroids have been tapered, and the intraocular pressure in the left eye is lowered and is maintained after the laser PI. Now, patient is tolerating mycophenolate mofetil well. The monitoring values of complete blood count and LFT values are maintained. Her vision has improved to 6.6 in both eyes, and the intraocular pressure by applanation tonometry is now at 12 millimeters of mercury. This is a clinical picture showing the patent PI and settled inflammation in both eyes. Thank you.
Thank you, Jinsi, for that presentation. Can you comment on the case? Your views?
This is a very well managed case. Yes, I do think the pattern fits with VKH, and so you couldn't see the fundus because of the iris bombay and the pinpoint pupil, but good thing you had the previous fundus picture and the FFA, which does look like VKH. And again, we would not really have done anything very differently at all. Started the patient, the AGPI, getting the patient on immunosuppressives and controlling the inflammation. This is the line to take with a chronic form of uveitis. It's very well managed.
Jinsi, will you stop
Thank you.
sharing that screen? What is your opinion on MMF? Do you think, we are giving MMF because that is available to the patients there.
Yeah.
But,
that's true. We also give MMF. Again, a lot of our patients are from the north, and the availability is not very reliable. So we still use a lot of azathioprine. And depending on availability issues, a lot of our patients are also on MMF. And it's for people for whom we don't have too close follow-ups. I am happier with azathioprine because it's an older drug, more widely available, less expensive, and many physicians everywhere are also familiar with azathioprine, so it is okay. But MMF also, but again, expense is more, and availability is sometimes an issue. So that is the only thing. Otherwise, yeah, we also use MMF.
toxicity is less, no? It's not very toxic.
Not really. I don't think there's been any. In fact, recently there have been 2 or 3 papers in which in the beginning there were a lot of papers which said that it was toxicity. But as time goes by, recently I think Dr. Ratnan's paper was there about how methotrexate was doing better than MMF and everything. And so I am really not. It's not something that it is so outstandingly different from any of the other immunosuppressives. So the impression for us also is largely methotrexate, azathioprine, and MMF are roughly equal. And again, if the expense has to be looked at, and I would rather they continue the care with azathioprine than have a stop and start and treatment with mycophenolate. It is not necessarily that. There are 2 or 3 recent papers here in which the efficacy of mycophenolate, it is not outstandingly different from anything else.
Thank you, ma'am. Thank you very much, ma'am.
Thank you.
No, I think one point that we should highlight here is that doing a peripheral iridectomy is important even if the inflammation is there. You have to, the intraocular pressure has to be reduced.
Yes. For us also, again, we'll just go ahead with the peripheral iridectomy. Sometimes it's very difficult to do that, which is why, even now surgical PIs, we still have to do it if it's not working out.
So any more questions, please? If not, we can end this session.
One question. You said the importance of PI. If there is active uveitis, will it not increase? Do you need to step up steroids?
Yes, we will give intense topical, even sometimes systemic, but sometimes if the pressure is very high, we will be lowering the pressure with other agents, the diamox, mannitol, all these things, so that we can get some view. And as soon as possible, we'll try and do the PI. Because if there is a lot of inflammation, it is actually impossible to do the PI. The iris tissue will be boggy.
Sometimes it will bleed also.
Will bleed.
A lot of bleed.
The fibrin comes instantly, and by the time in 1 hour it is already blocked. So it's not worth it if you. Even with there's only limited roles for topicals, the space involved is very little. So we do have, it's a difficult situation. It is a lot of anti-glaucoma medication and the steroid, and then as soon as possible the PI.
Thank you.
Okay. So shall we end the session? Any more? Andrew, sir? Yeah. So unmute yourself, please. Unmute.
The final picture shows some complicated cataract or anything. Some syndicate still there, some complicated cataract. Vision 6.6. It is very wonderful to see 6.6 vision. The picture shows some complication. Yes.
So no cataract at all, sir. Recently, last week only I saw the patient. Vision was actually 6.6, but seeing the pupil, we may wonder how the vision is 6.6. That's the problem. But she's doing well. She's tolerating MMF and doing well.
Good.
I have a question. Like, if we cannot do the peripheral iridectomy with the YAG laser, is there any harm in doing the surgical peripheral iridectomy in these patients?
No. Yes. We always, even now we do surgical peripheral iridectomy for some of our patients, because the YAG is, if it is possible, we'll definitely try 1, 2, 3, 4, 5 times, but we are side by side getting the patient cleared for surgical iridectomy. We have to do it even now in some cases, because sometimes there's no other ways.
What is the current guideline for doing cataract surgery in a patient with active anterior uveitis?
Again, we will wait till the uveitis is inactive, even if the cataract is advanced, and we sometimes even with the bilateral total cataract, in a chronic uveitis which has not been managed by people coming in from the north, sometimes still are like that way. We will keep them for another 5-6 months and then only do the cataract surgery, because it is absolutely pointless to do it when we don't have enough steroid or immunosuppression already in place. So there are very few situations where we may have to do it. That is when the cataract is that intumescent type and it's going to rupture any minute. And then, yes, we have to put in high dose of steroids and try and do the cataract as early as possible. But other than that, we will wait. We'll wait till there is enough control of inflammation and then do it. If the patient only has old uveitis and it is already, inactive for several years, then yes, we don't need very much steroid cover or anything for surgeries.
How long do you wait? Like, is it acute? They say 6 weeks, but does it otherwise for chronic cases 3 months? Or how long do you wait?
Yeah. If we can see, very often patients cannot come very much for a follow-up. So First, we'll get all the medication done and evaluate the patient in about 2 or 3 months' time. And that's the time when you decide how much of vision has improved. See, by then the patient's vision would have already improved. Some amount of the patient's vision may be because of the uveitis, not the cataract. So we may be able to prolong for some more time and then do it in a far more controlled fashion. And we always try and do a surgical PI, by the way, when we do the cataract surgery, for especially cases like this. So when you have the opportunity, do a small surgical PI also at the end of the surgery.
Madam, any experience on COVID-related uveitis?
No, not much really. Actually, we've been quite happy because unlike chikungunya and Zika and all these other things, I think all the coronaviruses, we've never had a problem, SARS or MERS or anything like that, even with COVID. There are few reports, here and there, high fever. Any high fever will cause a few retinal hemorrhages and some corneal spots. That's about it, really. It's not even a very specific COVID-related thing. So Ophthalm has been largely quiet during the pandemic. So that is one thing.
Nice to hear.
Thank you, ma'am.
Okay. So thank you once again.
Dr. Sujata, please give the vote of thanks.
Good evening, everyone. First, I would like to thank Dr. Amala in the name of all of Thrissur Academic Club of Ophthalmology, and on my personal behalf, I would like to thank her for their excellent presentation. I always have thought that uveitis is a very deceptive subject and it's very difficult to treat, and your presentation underlines that belief. And I think we have learned a few practical tips, many of us, like monitoring with this axial length and intraocular, what is the importance of the intraocular pressure monitoring, and also the need for adequate steroids therapy. Thank you, madam. Then I would like to thank Dr. Papa for chairing the session, and also Dr. Jinsi for making this excellent presentation. Then I would like to thank the senior faculty who has joined this session and made this discussions lively. Then I would like to thank everyone of you who have joined this session and made this a grand success. I should not forget to thank Dr. Rajesh Segumaran sir and KSOs for providing this Zoom platform, and Dr. Tanu for giving all the needed assistance. I thank everyone who attended, and thank you all. Thank you.
Thank you very much from my side.
Thank you and bye.
Discussion.
Super presentation by Papa and Jinsi. Slides are clinical photos, very nicely presented. So, third year PG?
No, she's our SR. Dr. Jinsi is a topper.
Okay, Jinsi. Done nicely.
And a very upcoming ophthalmologist. We can look for.
SR means he was I was an examiner for her.
No. She is from Calicut.
I see.
PG.
Okay. Goodbye, Amala.
Bye.
Thank you. Bye.